in the real world setting, it can prevent diabetes. And we found in this paper which we published recently that prevention of diabetes is possible in a real world setting in South India. Next I'll move on to kidney. Kidney, don't think that the kidney failure is a very slow process. It is a slow process, but you have to measure the albumin and the GFR, and this is from the KDIGO classification, and you have to measure the albumin and the GFR. We have drugs which can impact the kidney, the blood vessels in the heart now, and the standards of care of the ADA and ESD show that it can be treated at a very early stage if you measure the albumin and the eGFR. We recently published in the Indian Journal of Nephrology, Dr. Shivashankar is here and she's presenting tomorrow, and we found that body mass index is independently associated with CKD among people with diabetes. Therefore, we wrote up the global IDF guidelines for kidney some years ago along with Sally Marshall, which has been modified by Dr. V. Mohan and Antonio and others recently. In the 2005 guidelines, we wrote standard of care. The minimal care is about practiced in rural Bihar or rural Uttar Pradesh. Standard of care of where it is practiced in our clinic, in any diabetology clinic, and comprehensive care is where you do kidney biopsy to diagnose diabetic nephropathy. I'm talking about kidney in particular. So minimal care for the kidney is using beta blockers and treating the hypertension to 130/80, not bothered about the ACE inhibitors or ARB. Standard care is where you give ACE or ARB, and comprehensive care is where you do a kidney biopsy and try to find out the reason for the proteinuria and rule out non-diabetic kidney disease, which constitutes about 30% of the kidney disease which you see in practice. Next is our publication about the mind. We found out for the first time there's an entity called diabetes related distress, DDD, which is particular to diabetes in particular, and it is not associated with any other condition. So this was the first paper in India, assessment of diabetes related distress among subjects with type 2 diabetes. And more recently we found out how to avoid by using muscle relaxation technique. This was published in IGMR, Indian Journal of Medical Research. The effect of progressive muscle relaxation on the mind, and you can take the stressors away from you by using the method used in yoga. Yoga is quite useful. Pranayama is quite useful, meditation. And last entity is the lean diabetes, which is called type Y, type 5 diabetes. It is not type 5. Dr. V. Mohan has published recently in the DRCP that lean diabetes is a special variant of type 2 diabetes, whereby the failing beta cell cannot even cope with the small amount of insulin resistance. And this is the classification what we came up with several years ago. We have anybody above 23.5 as overweight and anybody above 25 as obese. And lastly, I will talk about diabetic foot, which is close to my heart. Diabetic foot is a condition which is associated with a lot of comorbidities, high direct and indirect cost, potential amputation is there, and the first two categories is where we physicians are involved. the normal foot and the high risk feet, and the last 1, 2, 3, 4 stages are with the surgeons, and it is quite costly to treat non-studded foot, infected foot, necrotic foot, unsalvageable foot. The cost was described in JAPI. It is the most expensive complication of diabetes you can think of, and this is diabetes without complication amputations if they are present. We have in this paper looked at the cost of expenditure for the last 2 years. You can see the difference between the two, $930 versus $3,000 if you have several amputations. So we have this innate responsibility of preventing amputations, not only saving the feet but preventing amputations. And lastly, for the RSSDI, we did the early screening of foot problems in people with diabetes, and Tamilnadu was the highest, and we found that 1/3 of the patients had a high risk feet who walked into the clinic, and this was published in the British Medical Journal 2 years ago. Lastly, I would like to talk about what we have done. If we import footwear from Italy or from Europe, you have to pay customs duty, and it costs about 14,000 rupees. So we published in the International Journal of Diabetes in Developing Countries, which is the RSDI journal, a study where we looked at a in-hospital made footwear called MV Surgi boot, and we tested it out in some patients. You can see that it healed, and it healed. It's mostly useful for 4-foot ulcers. And lastly, the 2027 guidelines are going to be written up, and it's already started, and I have been placed in 2 IWGDF guidelines on interventions to enhance wound healing and also in offloading. So I think it's possible to prevent diabetic complications, and I would like the chairpersons to ask any questions if there are any before I finish and hand it over to the President-elect, Anuj Maheshwari.
Thank you, sir. Thank you, Dr. Vijay. Given a broad topic of diabetes care, prevention of diabetes complications, I was wondering what he was going to talk about this broad macro, so many complications, but then he stuck to specific complications of diabetes related to kidney, musculoskeletal system and the foot. So thank you, Dr. Vijay. Is there any questions from the floor with regard to the topic?
Or we can have at the end of the session, sir?
Can have at the end of the session.
Yeah, sir.
Dr. Anuj,
Anuj.
Long live despite diabetes without the complications. That is the message he has given to this audience. Now let us move on to the next topic, that is diabetes care in rural India. Of course, most of us have been practicing in urban areas. Now I welcome Anuj Maheshwari to give these deliberations. Please.
Thank you. Thank you, chairpersons, for the kind introduction. Thank you, team Tamilnadu chapter of RSSDI, for this wonderful invitation. And I really feel privileged in having in last 4 months 4 times in the Tamil Nadu. Thank you, Dr. Shanmugvelu, for this wonderful experience of me. Started from, and I think out of those 3 times in the Coimbatore only. So, and despite I missed 1 or 2 invitation by Dr. Narsingan, still I could make it 4 times in Tamil Nadu. So next time I will definitely not going to miss your invitation, sir. So in next 20 minutes I shall be telling you about a vision which I really look forward in during my tenure of being president, because you people have elected me, so I must tell you something what is the preamble in the next 2-3 years we shall be going. And I'm really grateful of President Dr. Vijay Vishwanathan, who given me this opportunity to start these activities in his presidential tenure, and we are still started working in many states about 1 month back, we did the similar activity in Darbhanga at Bihar, and now on 17th of August we are going to have the similar activity at the Jharkhand. And very soon I believe that we shall be getting an opportunity to start this activity, rural outreach program of RSSDI at Tamil Nadu also. So let's talk about the challenges and opportunities which are there in diabetes care in rural India. So if we talk about the challenges, the two biggest challenges always remains in our mind. One is the rising trends of the diabetes in India. Despite so much of the efforts, despite so much of the tools in our armamentarium, our prevalence of the diabetes is increasing in last 20 years. It is proportionately very higher and higher. Means when it was, what was the speed of in the first 5 years, 2000 to 2005, in 5 to 10 it was more speed, and then currently also we are having a higher speed in spreading of this diabetes. Another important thing what remains in our mind, that diabetes occurs 2 decades earlier. It started occurring 2 decades earlier in Indian population. If we really look for in the background of these two things, obviously the rapid urbanization comes in our mind, which is in the roots of so many evils. But if you look over the Indian population's status right now, is still 64% population of India is living in the villages. Still we are largely is the rural India, not the urban India. When we talk about the diabetes, it is more focused about the urban population. It is always our all efforts to stop diabetes, for the prevention of diabetes, for the diabetes care, CGM, whatever we wish to do, that is targeted towards the urban population. Rural population is always missed by one way or another. For the first time, we could get an authentic data of the rural diabetes in the ICM or in diabetes study this time. But before that, we were not having a pan-India authentic data for the rural diabetes in India. Another important thing which would be more important here, now our villages are also getting influenced with the mass media. Physical inactivity is also starting in our villages also, because lot of facilities, lot of luxuriousness is reaching there also. They are also changing their dietary pattern, which have significant altered lifestyle patterns. And of course, the smoking, alcohol consumption, refined carbohydrate, rich diet, and all these things are also being more and more popular in the village population also. And because of what, lot of people remains with the hidden diabetes, which is not usually caught when we do not know the people. Obviously, we do not treat them, and many of those people reach to the complications like kidney failure, like cardiovascular disease much earlier than their urban counterparts. So if we look for the risk factors of the type 2 diabetes in the rural India, of course the socio-economic factors remains the biggest base for that, which is incorporating the limited healthcare access, poor health education. At the same time, those who are living in the lower socioeconomic strata are suffering more with these lifestyle diseases like diabetes and hypertension as compared to the others. Of course, the physical inactivity, changing dietary pattern, genetic predisposition is common with the urban population. But the additional risk factors which are getting more and more troublesome, like tobacco and alcohol use, poor education level, people don't know about their disease, so whenever their diabetes level comes to the normal, wherever glycemic level comes to the normal, they stop the treatment. Obviously, the diabetes self-care essentials, which includes the healthy eating, healthy coping strategies, problem-solving skills, regular physical activity, blood sugar monitoring, medication adherence, these are very poorly followed by the rural population. But most of the time, the biggest challenge comes to the blood sugar monitoring and medication adherence, because most of the people doesn't know about their diabetes. Obviously, the monitoring is not that much good, and at the same time, as I said, they stop their medications once they become the normoglycemic. If we look over this rising prevalence of the diabetes in the rural India, you can see it here. This rural India diabetes is following just the urban India, and it is 10 years ahead of the urban India, or you can say 10 years behind of the urban India. So when in 1990, 5.5% was the prevalence of the urban India, the same prevalence we could achieve in the rural India after 10 years in 2000. 8.1% was the prevalence at that time in the urban India, we could achieve the 9.1% prevalence after 10 years in 2010. And similar, you can see same prevalence which was 12.4 in the urban India, which has been achieved by the rural India after